first session after lunch, and I know that's always the hardest session because you're all happy and digesting, and so we try to do it a little bit more vivid, and we try to share some very interesting information about perfect models. And I want to start with just citing our session name, that is Pushing Barriers, Global Perspectives on Improving Patient Access. I do want to remark that for this session we have prepared a nice polling, so please don't forget to go into the app and take part in the polling. We are very curious about the outcome of the polling. And yes, to begin the session, we want to share with you for this session some numbers. We do have a colleague from the Market Research Bureau, Dana. And Dana, please, the stage is yours, and share with us the information, and then we take it from there.
Hello, good afternoon, everyone. Don't fall asleep because Svenja has some questions for you. So, sorry, they're searching for my presentation. Okay, current landscape for plasma and plasma-derived products. This is the MRB standard disclaimer. And over the next minutes, I will be talking about the global and regional 23 plasma collections, IG self-sufficiency, the plasma-derived market in 2023, with some focus, of course, on albumin, IG, and plasma-derived factor VIII, and to end up with some key takeaways. So let's start with global plasma collections. In 2023, about 86 million liters of plasma were collected worldwide. Of those, only 20% was collected by regions that were not the EU or US. That means that 20% of all plasma collected is used by roughly 85% of the population in the world. So for over the last decades, over the last years, this region have only collected 20% of all plasma that is used for plasma fractionation. China collects of those plasma, of all that plasma, China is collecting about 12 million liters, while the rest of the Asia Pacific collects about 4 million liters, and we will see later Middle East and Africa. So the picture is very different when we see some other regions. We see that collections in the Asia Pacific region is really growing. Growth is driving mostly from commercial plasma collections in China, but the rest of the region in Asia is growing too at a very nice pace, but still very low of what is the need of the collection. When we see Latin America, we see a different picture. We see that plasma collections have been declining in the region. This is mostly due to the closure of several plasma fractionation manufacturing sites, and therefore most of the population in Latin America, which accounts for over 700 million people, don't have access to plasma-derived product, or their access is very low. So how does this plasma collection translate to immunoglobulin needs, and therefore to all PDMP needs? Well, we have seen that only the US, North America, is self-sufficiency on IG thanks to plasma collection. We see that all the rest of the region in some levels have some deficit on IG because they don't collect enough plasma. That deficit could vary from one region to another, being very high in Latin America to less higher, but still a very important deficit in the European region and in the Asia Pacific region. How is plasma collected outside North America and the EU? Well, at least there are several models which plasma can be collected in those countries. There is a commercial plasma, there is commercial source plasma, which has been, as we are going to explain later, in China and Egypt. There is recovered plasma for fractionation and then manufacturing PDMP, which is such a very common model. which is used in a lot of countries in the Southeast Asia Pacific. It's used in countries such as, for example, Australia too. In Latin America is the most favorite model to collect plasma, recovered plasma. And then some countries like Tunisia, Morocco, or South Africa. Non-commercial source and recovered plasma is also collected from several countries. We have that in Japan, South Korea have that model. Countries such as Argentina and Venezuela have that model too. And lastly, both models getting together, commercial and non-commercial plasma from countries like Pakistan and Uzbekistan that will be somehow discussed after that. So the global plasma fractionation, it reached about $32 million in 2023, and it's mostly represented by North America, who has a 50% of the market. The next market is the Asia Pacific market, which is the fastest growing market in the region, thanks to sales of albumin in China, as we all know. Then is Europe with 20% of the market. Europe has the slowest growth, has the slowest annual rate growth of all the regions. And then we have Middle East, Africa, and Latin America, who represent together 6% of the region, but the Middle East, Africa is growing at a much higher pace than Latin America, which is growing at a slower pace. So, by product, if we see how is the market divided by product, we see that IG is about 60% of the market, represents more than 6% of all sales of the $32 billion is represented. So followed by albumin. Albumin represents about 16% of sales. Then we have specialty products, which include alpha-1, C1 esteroids, those products that are used for patients with alpha-1 and other indications. And we have two plasma-derived coagulation products, which includes not only factor 8, factor 9, von Willebrand factor, which is the only product that can treat patients with von Willebrand, and other coagulation factors. And then we have a segment who is called critical care, which includes PCC and fibrinogen, who is one of the fastest growing segments in the industry. As we can see, the plasma industry has grown, the market has grown about 7 times in 3 decades. It's a healthy growth, 7% annual, and as we all know, the industry is driven by sales of IG in North America and sales of albumin in China. Let's dive deeper into IG market. The IG market, as we all know, is highly concentrated in North America with over 44% of the market. There is growth in IG has been over 7-9% over the last year, so it's a pretty nice growth. Then we have Asia Pacific taking for about 26% of the market. Asia Pacific is growing at a very fast pace. The thing with these regions are that there is a lot of disparities among countries in terms of growth. So we have some countries that grow very fast and have very high per capita usage, while other countries have a very low per capita usage. Then Europe represents about 23% of the market. Per capita usage in Europe is quite high compared with the other regions. And then the Middle East, Africa, and Latin America together, they represent about 7% of the market. Latin America is, again, have very low prices. There is a undersupply issue constantly. And Middle East, Africa is growing despite with some very interesting efforts doing in the region. How is the access to patients in terms of IG? Well, we have many factors that contribute. We will talk a lot more about those, but mostly we're talking about economic factors like reimbursement, insurance coverage, payment, who pays for the therapy. Then we have other factors related more to the medical profession to get the proper diagnosis, to get recognition, differential medical practices. And then there is a manufacturer aspect that some of the industry are not present in some of the countries because markets are very slow, so there is almost no promotion of PDMPs in those markets. It's important to know that it's very different from the EU and the US, because whenever indications are approved or not, it's really not an issue in all these countries. IG is IG, and it's considered if it's for PID, for CIDP, it doesn't matter, it's just IG. It's very different than it is in North America. IG usage per capita, as we just said, is very high in the US, while countries in Asia Pacific, we will see that the average per capita is 19, but we have several very different, many difference among highest and lowest income countries. We take, for example, Australia has one of the highest per capita uses, the IG, compared with India, which is growing, but still is only 4 kilograms per million inhabitant, which is quite low. Then Middle East and Africa is a very low per capita income, but it's mostly all of the countries in the region has a very low per capita usage. And last but not least is Latin America with 18 kilograms per capita. There's some disparities among the regions, with Argentina having one of the highest per capita in the region thanks to a fractionation facility in Argentina, while other countries have very low per capita usage in the region. Moving forward with albumin, the albumin market was about 1,600 tons in 2023. It was mostly, as we all can see, formed by constituted by the Asia Pacific, which have over 60% of the market of albumin in 2023. North America and Europe were kind of 14-13% each of the market, with very relatively low annual growth rate if compared with the annual rate in China. Then Middle East, Africa, and Latin America accounted for the rest 10% of the albumin market. Latin America, as we see, showed the slowest growth in albumin. This is again due to a lack of fractionation facilities, the closing of this fractionation facilities, and mostly because of it's like undersupply because prices are too low, and so it's difficult for the industry to get into those tender markets. The albumin usage by region per capita, highest in North America. In Europe was pretty high, with very great difference among countries. And the Asia Pacific region, if we can see, is 242, but if we take China out of the equation, it goes down to 79 kilograms per capita, because China by itself, it's about 600 kilograms per million usage per capita. So it seems like a high usage per capita in Asia Pacific, but when we take China out, it's not that high. It's one of the lowest actually. And as usual, low per capita usage, what is translated is to very poor access for IG or albumin to patients. Plasma-derived factor VIII, this market has been in decline for several years. It reached its peak in 2018 with over 14 million units sold. Now it's less than 3.5 million units sold in 2023, with Asia Pacific and Europe more or less sharing 34-33% of the market. This is mostly, Latin America is about 13% of the market, and the Asia Pacific, and the Middle East and Africa, 11%. North America has the record lowest participation in the market with just 9% of the market, and its use is mostly in acute situation, emergency, just need some coagulation factors, so there is some, and it's used in prophylaxis for some countries that all they are searching is for a very low cost factor to treat patients. So to end up, to conclude with the presentation, the plasma-derived market has been growing at the fastest pace and is expected to continue to grow over the next years. PDMP's needs is supported by plasma collection. Every country has different models of how to collect and how to try to reach the needs of PDMPs through fractionation contracts, commercial source collection, other solutions, just in order to reach patients in need. Reimbursement, economic factors, and some political factors that we are about to see are really factors that influence the availability for patients of PDMPs. And IG self-sufficiency is only a reality in the US. The rest of the regions, they have different levels of deficit in IG, and albumin usage is growing in regions of the Asia Pacific, but in regions such as the Middle East, Africa, and Latin America, albumin usage, it only depends on how available it is, at what price, and that's it. And plasma-derived factor VIII, while it's declining, there is still some need in crisis and emergencies, and for those countries who cannot afford to pay for something more latest. Well, that is all. Thank you.
Thank you so much, Dana. I think I cannot stress out more how important it is that we get all these data. And I think we have to be very grateful that Market Research Bureau is doing this for many, many decades now. I think this requires another applause. Can I have my slides up? The second slide. Yeah, we just heard a very, very sad message that not really much changed in the course of the last 20 years. We're still highly dependent on US plasma. Many, many regions in this world have no access to care. That's why we have this session where we want to browse a little bit how to overcome this situation. And what is the reason actually for this situation? Luckily, we will bring today some very great examples. One example from Uzbekistan that I will present you, one example from Egypt, which Dr. Magdy will present, and a very great example also from Iran that Nariman will present. And then we will have also some very interesting insight from Takeda, the work that Takeda does, also in collaboration with the United Nations. So what are we talking about pushing barriers? Is it educational awareness? Is it the regulatory rules and regulations? Is it GMP? Is it reimbursement? Is it that we have to change something there when it comes to laws? Is it the blood collection? Is it the problem of the blood establishment or the situation of the blood collection in the country? Plasma donation, is it really only the plasma donation? Is it the fractionation accessibility? Or the manufacture of the PDMPs, a lack of fill and finish options. So let's browse all these ideas, and before we come into a discussion, let's share some wonderful examples. And the most recent one is Uzbekistan. We have invited the colleagues from Hematech to this panel, but due to their English, they said they they're happy to provide answers to some questions, and this is why I said I will agree to present their case. And I think it's a very great case. It's one of the most recent examples. So let me read you the answers and the questions. What was your motivation to open plasma collection centers? Currently, the country's own production of blood products is a matter of national security. I think that's a very interesting statement. A matter of national security. Plans to build a blood preparation plant in Uzbekistan have led to the creation of a network of plasma centers. So here, we have the statement that it was the plan to build a fractionation plant that triggered the plasma collection centers. Did you have to amend laws in order to have your centers opened? Yes, we had to change a whole block of legislations. I'm not very surprised by that answer, but I think it's good to see that, and I think we will hear a little bit from the other examples that we shared today. Did you have to amend laws to be able to send the plasma for fractionation to a different country in the EU? In the affirmative, how long did it take you to amend the laws? This answer really struck me when I read that. Yes, we had to change the legislation for the export of plasma abroad. It took us 6 months. 6 months, that's nothing. That's nothing. We're talking here being dependent on US plasma for more than 20 years. No, even longer. Uzbekistan, 6 months. Whoever has an idea how that works in 6 months, I'm very, very happy to show you this example. So there are possibilities. Now looking at your first center successfully open, what would you recommend countries that seek to do the same? Be purposeful and persistent. Be prepared to overcome difficulties along the way. So I do understand it's not a no-brainer, it's difficult, but it's worth it. And do you have a lessons learned for the audience that you want to share? It's hard to teach someone anything. Each country has its own subtleties. And you need to look for your own ways and solutions. And this is a very nice quote from their CEO from Hematech. The eyes are afraid, but the hands do. After only 6 months and changing the regulations, this is how the centers look like. I think that's really worth a big applause for Uzbekistan. The nation regulation was changed, the export regulation was changed, they introduced compensation and have already opened 5 plasma donation centers and more to come. And eventually the fractionation plant. So I think this quote is very, very interesting, and we should not forget access to care have to do with that the eyes are afraid, but the hands do. So the next speaker, I would like to introduce to you the second recent example, a shining example, Dr. Magdy. The stage is yours. And this is also something that will float your boat. Thank you.
Thank you very much for the PPTA to invite me today in this very interesting session. We are here to share ideas, to learn from each other. And we, as you see, this is an international session from different colleagues from different parts of the globe. So I'll take a few minutes to illustrate what's happening in Egypt. Right. Grifols Egypt was established back to 2021. We all know that we have patients, and these patients need this peculiar medicine, this unique type of medicine. And to have this medicine, we have to collect the raw material, which is plasma. Fact. So exactly this is what we are doing. We are collecting plasma through a chain of donors. We have 11 fully operational donor centers, 9 more to come. So a total of 20 will be operational in Q1 2026. The plasma collected for now is shipped to Spain to be processed and returning back to be used by the Egyptian patients. In the future, the whole process will be done in Egypt. For today, I can say Egyptian patients rely 100% on IVIG, human album, and factor VIII manufactured from the Egyptian plasma. What will we do with the surplus? Whole patients, the patients in the whole region will benefit from this surplus for sure. Back to 2022, we were in Berlin, IPPC. There was only one functioning center, and the others were in progress. It doesn't matter how they look, but the most important thing is that all our centers meet all the international standards in terms of regulations and quality, safety of the donors and the quality of the plasma. Back to 2022, on the left-hand side, you can see the desert of land full of sand. This is the plot dedicated for the manufacturing site. Today, the status today, down on the right side, where is the manufacturing site, the first phase. The first phase will look in the future. When we say in the future, in a few months from now, the first phase will be finished and operational. From day zero, we identified the strengths and the pillars that we would work for, strengthen and keep it in mind. One, strong commitment of the project from the partners, here, the Egyptian government and Grifols SA. Quality comes first. Quality is the responsibility of Grifols SA. We all know what type of quality is Grifols quality. We all know how such project is very expensive, and the parties did guarantee good financial support to make sure that the project is sustainably progressing. And the last point is the most important point, which is the people and the society. Let me elaborate more on the people and society. When we talk about the people, we talk about the donors, our assets, our heroes. Here, we managed to let the donor have the feeling of social responsibility and ethical responsibility towards having these valuable medicines available all the time. Available as well as sustainable supply all over the clock. In addition to others, economic compensations, medical checkup, lab testing, yes, our donors feel that they are part of the project. They are part of the responsibility of this project. And actually, we created a sort of national pride to have that sophisticated technology implemented in the country. More about the social community, our employee. We created more than 1,000 jobs for now, expected to be 2,500 by the completion of the project, and more from indirect jobs. Our employee receive a well-dedicated, structured, and the implemented programs provided by Grifols Academy in Egypt. Social communities, with collaborating with the different governmental offices, the Ministry of Higher Education, the Ministry of Youth and Sports, they gave us access to these communities around the center. We learn the people, we educate people. We learn them what is the difference between blood donation and plasma donation. And the importance, what is plasma, and the importance of plasma-derived medicinal products to changing the lives of the patients. Again, in the health sector, especially from the pharmaceutical industry, they knew that implementing such sophisticated and advanced technology in the country will definitely increase the level and raise the level of operations and the quality to other pharmaceutical industry. To take away messages. Number one, no one fits all. Each country must tailor its own model. Number two, long-term partnership and commitment is a key of success. And let me stand for a few seconds here, changing the legislations. Once the political decision, this is the most important decision taken in this regard. Once the political decision was taken to change the law, you heard in Uzbekistan, it took 6 months. I think we took less of this. We changed the law. And the most important in this regards, this was advised to us actually by Grifols. They said, guys, if you want to go to this industry, you have to change the law. And once we get this message, convey to the political decision makers, and the political decision taken, let's change it. Focus on quality. Nothing but quality. Public awareness is a very key whole and very important area to work with to narrow the communication gap, the knowledge gap of the community. There are more to come in the next few years. Thank you very much.
Thank you so much for this impressive presentation, and this is a wonderful example that gives, I think, everyone hope who is attending here, who is not yet collecting in this country, and also to those that are representing the patients, that there is a possibility how to overcome this. Let me present you our next speaker, Nariman from Darman, and let's share another wonderful example, and I think you have started way back. Please share your example with us.
Sure. Thank you very much. Good afternoon, everybody. Thanks for inviting me for this fantastic panel. Thanks to PPTA and you. I'm representing hundreds of people working in plasma industry in Iran. So I'm not only representing Darman, my company, but also several other companies active in the country. Our story starts more than 2 decades ago, when one entrepreneur in pharmaceutical industry have seen the example of a private plasma collection center in Germany. And he learned that it is possible to having more access to plasma. And for him at that time was very difficult to supply Iran with factor 8 for hemophilia patients that were like more than 10,000 patients exist in Iran at that time. And it was not easy just having an idea and implementing it in Iran. For him, it was like 3 years of discussion in different political states, from parliament, Ministry of Health, different bodies involved. So there were people pro and cons of the idea of having a private company establishing a plasma collection center, especially that they were talking about compensating the donors, and it was like a red line. At that time, the public blood banks were very much against that. So after 3 years of back and forth, so finally they decided to have a compromise. And having the first one operated in the capital, Tehran, and then see what is the result. Since then, we had ups and downs. But through these ups and downs, we developed a big network of source plasma collection centers in Iran, mainly in big cities. And through the years, we were in some years in peace with public sector. And we invite them to having more public-private partnership. And at that time, we had the opportunity also to audit and inspect with European authorities the public blood banks, and they become ready from the GMP point of view for giving their recovered plasma to pharmaceutical, to having more access to plasma. And it's now like more than a decade that these models, so collecting plasma, either recovered from governmental public banks, public blood banks, or source plasma, all together, sending it overseas, and then fractionated and take it back, the product to be used for local and domestic need, is becoming like a model. Even in some WHO sessions, they call it Iranian model, because Iran was the first country implemented with the help of know-how of Europe. At least in one of the guidelines of WHO, it has been recommended to have this idea of Iran model and Brazilian model at that time, which I learned later that Brazil didn't continue that direction, but Iran continued that direction for 2 decades. So this is the snapshot of, I'm not sure if you're seeing my slide, so if you can show the first slide. Oh, okay. Okay, if the audience is. So this is the snapshot of the guideline, so saying that if you collect domestically the plasma and then sending it overseas because you don't have the infrastructure of a fractionator, then it helps to having more resilience and self-sufficiency when it comes to the PDMP supplies. If we go to the next slide, then giving you some idea that, okay, what are these centers, okay, how much plasma we are talking about. So in the upper row, I showed that 28 recovered centers audited by European authorities. All together now in last year, we had close to 200 liters of plasma collected. Also 29 private plasma phoresis centers, so source plasma established, that close to 300,000 liters of plasma collected. So all in all, 500,000 liters of plasma from a country that 2 decades ago, it was the picture was like this. We had 20 plus governmental blood banks. They collect whole blood, they process it. There was some need of hospitals for FFP, they give it to the hospitals. For the remaining, they had a big headache how to destroy it. So there were plasma there, they could not give it to pharmaceutical, and they had a big problem, okay, how to burn it, how to destroy it, not to having the problem of the environment. Now, all of those plasma, after having audit and having the standard of pharmaceutical, going through having the fractionated and having produced PDMPs. And now, with access to 500,000 liters of plasma, it makes sense economically to having fractionator locally. This is why so far 2 small fractionators with chromatography technology already established, and Darman, my company, we are in partnership to having a fill and pack soon in Iran, and then later on probably going to more scalable technology like COM. If we go to the product in the next slide, Then we show with all of these how much self-sufficiency we have. So factor 9, almost 100% of what we need can be produced from this plasma. For factor 8, it's 60%, but it's, you can see 60% in my table, but please read it 100%, because that 40% is already supplied by recombinant factor 8. So for factor 8 also it's fully self-sufficient. And when you take a look at IVIG and albumin, 60+%. And we have the target of increasing the amount of plasma we are collecting to reach 100%. And still the struggle is there. I would like to finish my talk with two stories that touch my heart. One, almost a year ago, I had a message in my WhatsApp. Some unknown telephone number saying that, are you Dr. Sadri? I'm in need of finding IVIG. I didn't know her, but I'm a medical doctor by background, so I'm not like a CEO to say that, oh no, direct to somebody. I said, okay, what is the problem? And she was a lady from a very small city somewhere in Iran, and I have a very big fatherland, 90 million people living in a very big country. And she said that I have a prescription of IVIG, but there is no IVIG in my city. And I haven't asked her that, okay, what is it for? I said, okay, I will introduce you to one of the big cities close to your city to go and take it. And every other month, she again sent me a message, and I introduced her to one pharmacy. Last week, I received a message again from the lady, and it was not only a message, it was a message with a picture of a baby. And she said that she's my daughter, and I use IVIG for infertility reason, and I have it because of you. And it really touched my heart. So we are here, all colleagues, for millions of patients out there. Some of them probably we only see numbers, but when it comes to patients and the real need of the patients, I believe as a medical doctor that there is a meaning on our efforts and our collective efforts. And the second story, all of these slides, I have my deputy, the director of business development with me, Martina. She's here. She's also a pharmacist, PhD holder. And a couple of weeks back, we didn't expect to having a need of IVIG ourselves, but her sister diagnosed with Guillain-Barré syndrome, and she come to my office and said that, hey boss, I feel what is our vision and why we are trying, and the pharmaceutical medicine that we are producing also is our relatives one day will be in need of it. Thank you very much.
Thank you so much also for that wonderful examples and the insight in your personal history and some experience. Talking about patients, we have here a representative for the patients, Juçaíra, I think I pronounced it wrong, did I? From Brazil. So that is a very interesting picture that you get painted. There are countries that already managed, and we just saw the figures from Ghana, Latin America. There is not much going on. How do you feel about this, and how's the situation in Brazil? Maybe you can share something like that.
Hi. First of all, thanks for the invitation. It's a great opportunity to bring the patient voice here. I want to show some of the challenges we face regarding primary immunodeficiency in Brazil. Focus on diagnosis and treatment. First, our major challenger is increasing diagnosis rates. We have a lack of comprehensive national database to determine how many patients we have diagnosed across Brazil. The estimated number of diagnosed patients is around 2,300, but you know there is significant underreporting and many patients remain undiagnosed. There is also a notable shortage of specialized centers for diagnosis and treatment, which are mainly concentrated in Southeast region and few capitals. We also, regarding national neonatal screening for primary immunodeficiency, we have a law regulation testing this in May 2021 and came into effect in May 2022. However, the implementation is limited to some areas. Thus, 16.5% of the country's population make the law work. When it comes to treatment, immunoglobulin is our main treatment. It's a high-cost medication legally supplied by the public health system. Unfortunately, Brazil per capita consumption of immunoglobulin remains very low, around 16 grams per 1,000 inhabitants. This low usage is primarily due to underdiagnosis, but even diagnosed patients face difficulties assessing adequate amounts of medication. Moreover, immunoglobulin is only available in intravenous form with no options for subcutaneous administration. This is only possible through legal actions, court orders, or private insurance. Brazil's plasma policy also hinders domestic production of immunoglobulin. We don't need to just take the law. We need to change our constitution. Only the state-owned company Hemobras has authorization based on the constitution to process plasma collected within the country. However, plasma collection is limited to surplus from blood donations, and despite being founded over 20 years ago, Hemobras has not yet produced a single drop of immunoglobulin domestically. Meanwhile, we continue to import medication through contracts that are often scrutinized for suspected fraud. As a vast country with over 200 million inhabitants, Brazil would greatly benefit from producing immunoglobulin locally. Producing immunoglobulin with our territory would better meet patient needs, generate jobs, and foster industrial development, reducing our dependence on the international market. Every day, new uses in different diseases emerge, and the expected increase in diagnosis of primary immunodeficiency will only rise demand. Unfortunately, with the current plasma policy, the outlook is not promising. We need to rethink our